Desai.
Good afternoon. I'll be presenting on comparison of pre-puncture ultrasound imaging in the transverse median and parasagittal oblique planes for lower thoracic epidurals. Thoracic epidurals today are the commonest mode of analgesia in open abdominal surgeries, which have been classically put by palpation of bony landmarks and the loss of resistance technique. Over the last decade, ultrasound use has evolved for pre-puncture identification of the intervertebral space, the estimation of the epidural depth from the skin, and the approximate direction of needle insertion. And its use has been demonstrated in both the planes for lumbar epidurals for labor analgesia as well as thoracic epidurals for abdominal surgeries. The aim of our study was to compare the two planes in accurately predicting the depth to the epidural space, the point of needle insertion, and the angle of insertion in lower thoracic epidural needle placement for elective open abdominal surgeries. It was a prospective randomized pilot study between February and May 2013. Written informed consent was taken from all patients, and patients over the age of 18 years of age, physical status 1, 2 and 3 undergoing elective open abdominal surgeries under general anesthesia with thoracic epidural catheter placement for postoperative pain relief were included in the study. After securing intravenous access and having standard monitoring in place, the scanning was done in all patients by a senior consultant with 5 years experience in neuraxial scanning, and the catheter placement was done by a junior consultant and a fellow with minimum 3 years training in the procedure. The measurements were done with an inbuilt caliper on the ultrasound machine, and the patients were randomized to either group by simple randomization using SPSS. The scanning was performed with a curved array probe of 5.5 to 2 MHz with the patient in sitting position with the upper back and neck flexed in a non-sterile manner before the epidural procedure. In both the planes, the scanning began with the identification of the upper border of the sacrum, and the probe was then slit cephalid, identifying alternate laminae and interspaces until the appropriate dermatome according to the incision was chosen. So in the parasagittal plane, the probe was placed 1 to 2 centimeters laterally away from the midline, tilted obliquely to view the spinal canal, and the following structures were identified: the ligamentum flavum and posterior dura complex, the vertebral body and vertebral dura complex, and the upper and lower laminae. In the transverse plane, the probe was placed perpendicular to the long axis of the spine, and the midline was identified by identifying the spinous process, and the following structures were identified: the ligamentum flava and posterior dura complex, the vertebral body and vertebral dura complex, and the 2 articular processes and the transverse processes. In both the planes, once an optimum view was obtained, the image was centered on the screen and frozen, and the transducer was stabilized, and the skin was marked at the midpoints of the upper, lower, right and left borders. The probe was then removed and the lines were drawn to join these marks, and the intersection of these 2 lines gave the point of insertion, and the direction of the probe, which gave the best view, determined the direction of needle insertion. And the distance from skin to inner aspect of the ligamentum flavum durometer complex was measured and was marked as the UD in both the planes. So these are the insertion points in both planes. And during the scanning in either planes, image quality was rated as good, poor and inconclusive, and time from application of probe to the skin to determination of point of needle insertion was noted as time A. The operator performing the catheter placement was informed about the interspace, the insertion point and the direction, but was blinded to the estimated depth. The plane of insertion was same as that of the ultrasound scanning. Under aseptic precautions, epidural catheter placement was done in a routine manner with a 17 gauge Tovey needle. The space was identified by loss of resistance to either air or saline. Once the space was identified, the needle was marked with a sterile marker at the skin, and after catheter insertion, the needle was removed and the distance was measured with a ruler to the nearest millimeter. After which general anesthesia was instituted and intraoperative analgesia was maintained as per institution protocol. The time from local skin infiltration to insertion of the epidural catheter was noted as time B. The outcomes measured was precision and accuracy of the estimated depth to the epidural space as measured in both planes compared with the actual depth in actual needle insertion. And secondary outcomes were accuracy of the insertion point as determined by number of reinsertions and the number of redirections, duration of the scanning and the epidural procedure, pain during the procedure assessed by verbal rating scale from 0 to 10, complications and quality of the image. Statistics were done with SPSS with descriptive statistics for continuous data and percentages for discrete variables. Concordance correlation coefficient, you use degree of agreement between the estimated and the actual needle depth, and Blonde-Altman analysis was performed to place the magnitudes between the 2 measurements in a more clinical context. 30 patients were recruited in the study, 15 in each group, and one patient in each group was excluded due to technical difficulties in the epidural placement and the ultrasound scanning. Demographically, patients were comparable in both the groups. The results in both the groups were there was no statistical difference between the two groups. In both the mean ultrasound and the mean actual needle depths, the difference between the two, the 95% limits of agreement and the concordance correlation coefficient. Blond-Altman analysis showed that most of the measurements were close to within the 95% limits of agreement in both the groups. And concordance correlation coefficient showed that all the measurements were in linear agreement and close along the 45-degree line. The overall image quality was good and in most of the patients, with poor image quality seen in only 5 patients in the transverse median group, which was a statistically significant difference. There were no reinsertions, and the redirections were seen, 2 redirections were seen in the parasagittal group, while none in the transverse median group, which was again statistically significant. All the patients had successful epidural analgesia without any complications. There were no statistical difference between the mean time of the scanning and the epidural procedure and the pain score between both the groups. So various studies have proven the efficacy of pre-puncture ultrasound scan in both lumbar and thoracic epidural catheter placement, but this is the first attempt to randomize patients to one of 2 groups to determine if one is superior to the other. There was very good correlation between both the estimated depth and the actual needle depth in both the planes, but the higher number of redirections in the parasagittal plane is perhaps due to difficulty in reproducing the exact oblique angle of the ultrasound beam along the upward direction of the needle, as was also seen in a similar study. And better image quality could be attributable to a wider acoustic window in that plane, which has been proven previously in a comparison between MRI and ultrasound. So we have demonstrated a good success rate of ultrasound guided technique at first attempt with minimal patient discomfort, as it reduces the number of redirections required in the blind technique. The limitations of our study were it was a small sample size and inability to correctly determine the angle of the ultrasound beam and the angle of needle insertion. So this pilot study demonstrates that pre-puncture ultrasound can reliably determine the needle insertion site and the depth of the epidural space in lower thoracic spine, with the parasagittal plane giving a better image quality than the transverse median plane. However, a study with a bigger sample size is needed to confirm these findings. Thank you.
You need to write it up quickly because a similar study has been published.
Yes, sir.
Right? You know that. So.
Yeah. Thank you, sir.
That was a nice